going to introduce Dr. Valery Uhl. She's a radiation oncologist. She received her medical school education and fellowship in radiation oncology from UCSF. I first met Dr. Uhl in 2003 when we shared a brachytherapy patient, when you were doing brachytherapy back then. She's a board-certified radiation oncologist, and she loves at this point to do breast intraoperative radiation therapy. She practices out of the Altabate Summit Medical Center as well, and sees patients in Emeryville and Pleasant Hill in Dublin and Oakland. What you don't know about Dr. Uhl, but I know, is that she was the 2016 recipient of the American Cancer Society. They honored her in December at a very nice function. And what you also may not know about Dr. Uhl is that she owns some vineyards up in the Russian River, and she judges wine for multiple wine competitions all over the world. She's got a great nose. So welcome, Dr. Uhl.
Thank you so much for coming and hanging in there for the last talk. Luckily, mine is relatively short. San Antonio is not known for big wows for radiation oncology. So I'm giving you the wows that I found, plus a little bit more about our highly successful intraoperative program since we just published in the Annals of Surgical Oncology. And for a community-based practice, that's really something awesome. So first, the three highlights I'm going to talk about is first going with stage 0 breast cancer, DCIS. DCIS is not invasive cancer. We're seeing more and more of it because it's found so easily on mammograms. And we're trying to figure out, again, the theme of less is more, who really needs radiation? There are people who don't need radiation. A lot of them come to me to see, do I really need radiation or not? So there's a new predictive test that's going to be coming out for DCIS. Also, the one big issue in radiation at the San Antonio meeting was those women who undergo mastectomy and opt for reconstruction and need radiation. What are their outcomes? How do they do? And does the type of your reconstruction matter? Of course, yes. I'll be going into that in great detail. And then the emerging radiation techniques, targeted radiation. We used to always think you have to treat the whole breast, always. Now you can do accelerated partial breast radiation. You can bring down your days from 7 weeks to 4 weeks to 3 weeks to 1 week to now, as I did today, 30 minutes. That's all your radiation for your entire course. So first, the new DCIS predictive test. Decision RT test by Prelude. What they do is they take either your biopsy or if you had your cancer out, your whole entire cancer piece, and do a risk profile. It's about your tumor biology. You've heard about that in other tests like Agendia's MammaPrint, for example. And this is specifically for DCIS. They go ahead and look at the tumor biology, and then they go ahead and look at clinical and pathological risk factors, such as how large it is, margins, grade, and they have these algorithms that they go through. And they go ahead and predict an individual risk of recurrence sometime in the next 10 years, not just 1 or 2 years, 10 years. And this is the first biological risk signature test designed specifically for just DCIS. It's not just a genomic test. It helps identify patients who are at high risk for recurrence, and those are the ones that we should be irradiating. The ones that are low risk for recurrence, do we really need to irradiate them? I can ask you this room, if you knew that at 10 years your risk of recurrence was going to be 10%, do you think that's pretty low risk? These people think it's low risk and that maybe you don't want to even opt for any radiation. The high risk group were those that had a 30% risk of recurrence at 10 years, so a score of more than 3 in their score pattern. So 30% risk, a 1 out of 3 chance of a recurrence in the next 10 years. Most people would say, I'll take that radiation, especially if you're going to get me down below 10%. But if I know that in the next 10 years I only have a 1 out of 10 chance of recurring, maybe I don't want to do radiation. Next slide. So what they did is they went ahead and decided to do a validation study in 3 countries. This is what's unique about this. They chose the US, in which Kaiser of the Northwest was the first one to report their validation study. 2 more are coming along independently, 1 in Sweden and 1 in Australia. And Kaiser went ahead and looked at all the women they could find that were 26 years or older who had only DCIS and no other breast cancers ever, no history of breast cancer. So 26 to like 110 years old. Anybody with pure DCIS. Over a really long time, because don't forget, they're looking at 10-year follow-ups. It's a retrospective study. They take all those ladies, and they go ahead and run this test on all of them, even though they had their cancer years ago. And then they go ahead and see what the risk categories are, and then they look, how did those women do? And sure enough, this validation test showed that there were patients that were at high risk, 30% or higher, that when they had their radiation, it reduced their risk down to less than 10%. And then there was this group of women who had a really, really low risk, just 10%. And a lot of them got radiation, because remember, this is a looking backward study, a retrospective study, and sure enough, radiation reduces your risk. But if you're at 10%, it reduces your risk down to 5%. So for some people that might be worth it, for other people it might not, because that's super, super low. So we're going to be waiting to see, these other 2 validation studies are coming out later on this year, they believe. And this might be a test that if you have DCIS in the future, your doctor may order. Because a lot of us feel that we overtreat DCIS. It's not invasive cancer, and we might have a chance now to actually really feel confident that you have a low-risk cancer and would not benefit from radiation. And that's the kind of discussion we'll be having with your radiation doctors, and these kind of tests will be going on. So that was pretty exciting. The really big controversial thing at San Antonio was what to do with ladies who undergo mastectomies for their breast cancer, who want reconstruction, and who need radiation. What's the timing, what's the type, etc., and what happens to these women? Because a lot of people feel, oh my gosh, if you have reconstruction, you shouldn't get radiation. But what if you're high risk and need it? And that's what I see a lot of ladies do. So this was a consortium of a number of institutions, 11 institutions, collected data. It's called the Mastectomy Reconstruction Outcomes Consortium. It's a prospective study, so they looked at these people forward, but the ladies got to decide what kind of reconstruction they wanted. It turns out the median age is 49. That's pretty young. So most of these are usually younger women getting mastectomies and wanting reconstruction. And it was over 3 years. And what they found when they looked at all their patients, 553 received radiation, and 1,461 did not. Now this is very important, because why do some get radiation and some don't after a mastectomy? Some people used to think, oh, I get a mastectomy, I don't need any radiation at all. Not true. This is the always sad thing for me to tell people if they're considering reconstruction. If you have a large lesion, if you have positive lymph nodes, if you have very close positive margins where the surgeon's worried, you may still need radiation after a mastectomy. So it turns out anywhere from a third to half of women getting mastectomies will need radiation. It's very important to talk to your radiation doctor early to find out if you might be one of those ladies, because that may influence your decision about a mastectomy, and it may also influence your decision about the type of reconstruction you want to have, because that's what the next part of this report was. So they looked at these ladies, go back to that, the autologous, back one slide, autologous patient's own tissue reconstruction. So I'm going to explain, those are the tram flaps, deep flaps, latissimus dorsi flaps, where you're moving tissue around to give you a new breast, okay? So you had a mastectomy, and they're usually done immediately. This is also important. At the time of your mastectomy, you're having your reconstruction done right then and there. Versus the other group had implant reconstruction. That's where you have an expander put in, you're expanded, and later on you're swapped out for a silicone or a saline implant. Much faster, a lot less surgery. So a lot of people like that idea. However, it's often done not at the time of your surgery, your mastectomy, but later. And this is part of the rub why I don't like this study. You're really not comparing apples and apples and oranges and oranges. One group's getting their reconstruction immediately, then they're all healed, get radiation through that reconstruction, and you'll see that group does better. The other group gets their mastectomy, gets radiation, and then later is getting reconstructed with things putting in to try and expand tight tissue after mastectomy. So the complications post-reconstruction were looked at, things like hematoma, wound infection, as well as patient satisfaction surveys at 1 year after their reconstruction and 2 years after the reconstruction. So what we found was at 1 year, the ones that had radiation, no matter what type of reconstruction they had, 28.8% of these patients had some sort of complication, and 22.3% of the non-irradiated patients had complications. So right around, let's say, 25%. That's this is the way it is. This is a lot of surgery. Reconstruction is multiple surgeries with mastectomy. It's not just one. 2 years, though, you see a little more because a lot of these women now are getting their radiation in the implant group. You see a higher risk of having some sort of complication in the irradiated patients of 34% versus 22.5% in the non-irradiated patients. So radiation was linked to more than double the odds of developing complications in patients who received implants, and patients showed significantly lower reported satisfaction surveys or scores. However, what's interesting is that's the implant group. Remember, that's where their surgery is done much, much later after radiation. The radiation therapy is not associated with complication for those who receive autologous reconstruction, and patients did not report lower patient satisfaction scores. Those are the ladies who are getting immediate surgery, everything's healed, and then they get their radiation. So you can just imagine these are very different groups. Next page. So conclusions that I want to point out, because everybody went, oh my gosh, radiation's really bad if you're going to have reconstruction. That's not true. That happens to be one of my specialties. I take care of young women with left breast cancer, IORT, and women who are getting reconstructed or have been reconstructed in the past, let's say for augmentation, who then develop a breast cancer and don't want to lose their implants and want radiation. So this is don't forget, this is an observational study. So cause and effect cannot be established. This is just interesting information if you are a true statistician. Also, patients treated at centers skilled at integrating implant-based approaches with radiation therapy could still do well with such an approach. So, those are the ladies where when I see someone and they want an implant, I have them get maximally expanded and all ready for their implant before I do the radiation. So they're a lot more like the ladies getting flaps. They're getting a lot of their surgery done early. Then all you have to do is switch out the expander for an implant later. PMI, post-mastectomy radiation. Don't forget, the majority of these patients didn't have that because they were stage 1 and 2, no lymph nodes, didn't need radiation. The group that got radiation and were reconstructed needed the radiation because they were high-risk patients with high-risk features. So again, you're not really comparing equal groups. You have to be careful here. So these ladies had often very large tumors, positive lymph nodes, or positive margins, because it's a lot easier to go through reconstruction with no radiation at all, but that would mean that you're a stage 1 or stage 2 N0, meaning lymph node negative breast cancer usually. Trials are also ongoing, looking, and as you just heard from Dr. Marshall and also from Dr. Goodwin, the B51 trial and other trials are looking at women who have to get mastectomies and looking to see how much radiation we really need to give, because the amount of radiation you give and where you direct it also influences the tissues involved and whether they can be reconstructed easily or not. So I just want to mention that if you see a lot of this in the newspaper, remember this is interesting and food for thought. You have to talk to a radiation oncologist as to how they integrate reconstruction with their radiation. That's really important. Next slide. So now the real interesting stuff that's coming out and becoming very popular in the rest of the world, targeted radiation for breast cancer. All these forms of targeted radiation are accelerated partial breast radiation, where we learned years ago, guess what? If you're going to get a recurrence in the breast after radiation, it tends to recur within an inch of where it was. So why are we treating the whole breast for early stage breast cancer? We should be concentrating just on where the cancer was. But that's tricky because after surgery, the clips move around, as we've heard. I get a lady sometimes many, many months after their surgery. Where was their cancer? It's not that easy. And if they had reconstruction and tissue moved all around, it's really tough. So what they came up with is a really neat way to give the radiation at the time of your initial surgery when you are getting lumpectomy, so breast conservation. This is for lesions 3 centimeters and under. Okay, invasive ductal cancers, not lobulars. It's being looked at for DCIS and lobular, but right now it's for invasive ductals and that are usually less than 3 centimeters, ideally around 2 centimeters or smaller. You can get chemotherapy later, so it doesn't exclude that. We like to have lymph node negative patients because the more lymph nodes you have, the more likely you are to need regular radiation to your lymph nodes. This is in lieu of all the radiation. Radiation's normally every day, Monday, Tuesday, Wednesday, Thursday, Friday, for about 15, 20 minutes, typically for anywhere from 4 to 7 weeks. You can work and do things, but let's face it, that's not fun coming in every day. We're like an extra job in your life. I have these lovely, lovely ladies in the audience who work with me, and they always greet the patients with big smiles, and my patients always go, Dr. Uhl, it wasn't that bad. Your staff's so nice. But let's face it, coming in every day for many, many weeks is not fun. So what you do the time of the surgery is you go in, remove the cancer, make sure that you got it all. We send it off for x-rays and make sure we got it all. And then we go ahead and put in a very special device right there where the cancer was. So it's really hard to miss because you just removed it, and treat. And next slide. It's been reported now twice. It was a huge international trial with centers all over the world. And we had over 1,700 women in each arm comparing just intraoperative radiation with regular whole breast radiation. Their first report was in the Lancet Journal in 2010, and the second was an update in 2014 because people said 2-year follow-up's too short. Now we've got 5-year follow-up, and we have thousands of women in this trial. Some of you I gave a little handout about. And it's called the Target A trial because it's targeting radiation at the time of surgery. You get your IORT, intraoperative radiation, and that's it. If you happen to have, after surgery, any bad prognostic indicators or high-risk features, you can always still get whole breast radiation. It does not preclude that. And this trial showed that basically side effects were really, really low. You, of course, had a lot less skin side effects with intraoperative radiation. You had a few more seromas, but it wasn't statistically significant. And right now, the local control rate when done up front with that very first surgery is similar to regular radiation. So it's really taken on throughout the rest of the world. And I especially like to offer it for any woman who's over 70 because there are studies right now showing that over 70, sometimes you may not even need to treat the cancer at all, especially if it's ER/PR positive and you promise me you'll go on tamoxifen or an AI. But sometimes people say, hold it, 5 years of a pill or 30 minutes in the operating room? I'll take the operating room. So next one. So this is what it looks like. That's our machine on the left. It's quite mobile in the operating room. These are the applicator sizes which go into the whole of the breast depending how big your cancer was. We attach it, that little end piece, the applicator, to a very small linear accelerator, plop it into the breast like that. I'm the only one with only the radiation oncologist has the password, not the surgeon. So I'm in charge. I'm a control freak if you haven't figured that one out. I put in the codes, do everything, and it's about 30 minutes in the operating room. And you are done. And that's it. And no more radiation if everything looks good, which is usually in 85% of our ladies. Next slide. This was the schema of the trial again. Early stage breast cancer. It was a phase 3 prospective randomized trial, which is a class A trial, the best trial around. This is not some I'm looking backwards to see what I did for the last 10 years. This is everybody's treated the same and a computer decides which way you're treated. My hat's off to these women because these are two drastically different ways of being treated. And like I said, thousands of women signed up for this throughout the US, including at UCSF where I trained. And so as a result, you went through this, half got just IORT, half got regular radiation. If everything looked good in the end, you stopped, that was the end of your radiation. Next slide. So we started doing it because this trial had, like I said, almost 3,500 women aged 45 and older, invasive ductal, 33 centers in 10 countries around the world. Half got intraop radiation, or target as we call it, half got regular radiation. It's a non-inferiority trial, so it showed it was not inferior, and now that we have 4 or 5 years of follow-up, it's showing that if you do it right up front, it equals regular radiation. Next slide. The big important thing is they did allow people to go ahead and get this at a re-excision or later OR time. So let's say you got your breast cancer out, you heard about this and said, oh, I want that. The surgeon said, oh, it's okay, I'll go back in and do it for you. Those women didn't do as well. So I don't recommend that, and we in general have not been doing that in ours at Summit. So that's really important. So we call that pre-pathology up front. The local recurrence rate's like 1%, really, really low. It's great. And then we also looked, the London group looked to see how did people do over the years. And what was very, very interesting is that there were less non-breast cancer deaths in the IORT arm, more cardiovascular deaths in the whole breast external beam arm. And many of you have read about that. Left breast radiation could give you a heart attack, things like that. That especially was true in the 70s and 80s when I trained, because we didn't have really good devices to figure out where the heart was, really angle right. We've done a whole lot better, especially in the last 10 years. And if any of you have been my patient and get whole breast radiation, you know I do a lot of very special techniques with breathing and all in order to get off your heart. But this was a huge international trial where the majority of centers were doing nothing special for left breast. So that's why I think the IORT arm looks so good, is because it's local radiation. You're not treating into the lung, you're not treating into the heart. You're only treating about 1 to 2 centimeters right around where the cancer was. It's partial breast radiation. So that's really interesting, and I encourage the London group to try and publish more about that, because that's a big issue for left-sided breast cancer. The other thing I noticed was with radiation, if you have a pacemaker, you normally have to move the pacemaker to the non-irradiated side, because we can actually turn off pacemakers with radiation. With IORT, inter-op radiation, you're treating such a small little area that as long as your cancer isn't right beneath the pacemaker, you can, I've done now 2 ladies, they've done super. Pacemakers up here, cancers here, here, here. We treat them, we don't have to move the pacemaker, they get all their treatment, pacemaker's functioning great. So I just got a grant to write a paper on that, because that's a nice little niche for intraoperative radiation for women with pacemakers. Next slide. So the results at 4 years are neck and neck. If you do the IORT up front, that's real important. Next slide. A company called Zoth says that they can do it too. This is not intrabeam. This is not that huge trial that was done. You have to be careful. It's simply another company with a different kind of radiation machine that's not even the same energy. So be careful. ZEISS is the company that makes intrabeam, and that big trial was part of. We've had our program now for over 5 years, and as I mentioned, we just published our data. And again in the Lancet in 2014, the big trial got updated. We participated in the USA trial, where all the USA sites that could got together and put all their data together to see how do we look compared to the rest of the world doing intra-op radiation, universities and community settings. And we were the biggest community setting group that entered patients. Next. And it was just published in September, the Annals of Surgical Oncology. It's a retrospective trial, meaning that everybody who participated simply entered their patients and were followed, and Dr. Bailey's group and my group entered all of our patients. We have over 250 patients now that we've done over these 5 years. Our first year is now hitting 5-year marks, and we've only have 2 recurrences, which is really awesome. So when they sub-analyzed our data, it turns out we're some of the best in the nation, and that's why I'm getting a grant to write the paper, I think, because I work with really great surgeons, I think, that care about margins, as you heard, and do the right stuff so that when we go in, we really know what we're dealing with and have very few surprises. That's real important. And I truly believe this is the wave of the future. There's Dr. Bailey working on someone right now. We just did another case today. And so you can do it as the boost. You can do it as all the radiation at once. For older women, that's really great. For younger women, I like to do it as the boost because there's not enough data yet on women under 50. So I'm kind of careful about that group. And as I said, we're now at 5 years with our patients, and we've been very pleased with our outcome.